Let's talk about golfer's elbow. And golfer's elbow basically is a medial epicondylitis. We have several muscles that share a common tendon at the elbow. And when you've got that, you overuse them, you've got a tendonitis kind of a situation. And we really overuse the term tendonitis to begin with. Most they've shown in studies, actually in people, in autopsies, they've taken tests of people who've had tendonitis diagnosed, and they opened it up and realized it's not there at all. It's actually tendinosis or stuff going on with the sheath. But we just kind of call it that, even though it's not. But be aware that a lot of that issue when it comes to golfer's elbow, the medial epicondyle aspect of that tendon, it gets overused. And I've done many, many techniques over the years. I tried a lot of things, and I found the best treatment, bar none, is cross-fiber friction and ice. You got to grind the heck out of that thing and then ice it afterwards. There's techniques out there that chiropractors use called Graston techniques. I call it Rolfing with a stick. It's a steel tool with a lubricant, and it does work. It's very aggressive, but it's the same idea. You're breaking down scar tissue. I prefer to ice afterwards because they'll have less pain throughout the week afterwards. But that aggressive cross-fiber friction will make a big difference in diminishing the injury. Again, the recipe for that, typically with most clients, is 30 seconds of really aggressive grinding, followed by ice until it stays cold, and then do it about twice in a week with a couple of days between. And most people recover from that, unless there's a perpetuating factor that caused that repetitive use to initiate the injury to begin with. So the opposite is tennis elbow, and that's lateral epicondylitis. Again, it's a constant repetitive use syndrome where the person has done something like they're doing chainsaw work or painting, those kinds of things, and causing that to get aggressively inflamed. And we want to go in there, aggressively grind it, and then ice it. We'll show you that technique in a few moments. Real quickly on hydrotherapy when it comes to ice. The best kind of ice hydrotherapy is actual ice. There are things that trick the brain, which I call the squirrel techniques. And so when you use sombra or other things that either make it feel hot with a capsaicin type of pepper, or you got something that makes it feel cold with a menthol, it tricks the brain, and basically it's squirrel. It's like the brain is looking at something else, and it decreases pain and makes it feel better, but it's not actually taking care of the problem. If you have inflammation, it needs ice to actually drop that down, or some other anti-inflammatory to deal with that. But it does help to distract, and a distraction is fine, but it's not actually doing what you think it's doing. So if you're doing hard cross-fiber friction and you put an ice gel on there to take care of it afterwards, it may feel good, but the next day they're going to be in pain because you never actually dealt with the inflammation. So make sure you're using really true heat for heat, really true ice if you're trying to get them to cool down. But sombra or something that's going to make them feel like it's heating up is not actually going to warm the tissues up. It's just going to make them feel warm. Right? So it does have some kind of a secondary effect from a neurological standpoint, but not nearly as much as the real thing. So use real heat and real ice. Let's talk about carpal tunnel. So carpal tunnel, I don't want to get off into religious philosophy of creationism versus evolution or whatever, but I will tell you the hand is the most amazing structure I've ever seen in my entire life. When you look at the hand, you've got basically, it depends on which layer of cutaway you're looking at on dissection, but you've got a crisscross ligament, you've got a strap, crisscross, a strap, another ligament jumping through another ligament, and it's the most amazing thing. It's really cool. And what happens is, let's imagine if you want, this is a bow and arrow, right? This is the bow. You guys seen a bow and arrow before? Okay, so we have a bow with a very spongy string. And if I were to straighten out that wood, that string would lay against my arm, right? And if I pull my bow back, it would bounce back out again. Well, I've got muscle and I've got tendon, which goes into my fingertip. So why is it when I move my hand, those tendons don't pop out? Well, because I've got Scotch tape, which some call retinaculum. I've got a transverse ligament, and I've got these nifty little ligaments that keep all that tendon all the way stuck to my hands to the very, very end. And so it's a nifty gliding system until it starts to not work. And who gets carpal tunnel? Well, is a person swinging a hammer get carpal tunnel? Not usually. It's the guy that gets the nail gun going, right? Repetitive use. Or dental hygienists, or hairdressers, or data input. Small movement that's repetitive over time warms the area up and gets kind of gunk. This is a simplified, arguable discussion on carpal tunnel. That's my take. I'll tell you what. So what happens is the doctors come in there, it gets inflamed, it gets more and more compression, of the gunk builds up over time, lack of use, it gets inflammation. They say, hey, I know, let's just cut this little guy, pop that open, takes pressure off the nerve. Oh, doctor, you're amazing. Thank you so much for that work. I really appreciate it. And then they go back to their jobs, and 2 years later, guess what? They have carpal tunnel again. They go back to the doctor and says, well, it worked the first time. Let's try it again. What he says next, when he says that, that's malpractice from my perspective, because he knows it's not going to work. The point is, if it's not moving, get it moving. Movement is life. Lack of movement is death. Lack of movement is carpal tunnel. So we get in there, we do this technique, and we're going to break up that scar tissue, break up that area, get it moving, and get the area able to get the fluid it needs and get the whole circulation going and get that to break down and show them some self-stretching. So we have to break that up to get that to take care of itself. And it works. This is actually one of the best business builders I can give you. I never charge for carpal tunnel work. I can do it in less than 5 minutes between patients. And for years in our area, I would see people with a splint on it, say, hey, do you have carpal tunnel? Oh, yeah. Are you scheduled for surgery? Yeah, I'll make you a deal. Here's my card. I'll work on you twice in a week. It takes about 5 minutes each time. I'll work on you between my clients. I'll work on you, and I guarantee that if you don't have to cancel your surgery after 2 or 3 treatments, I'll give you $50. Again, they go, what? I say, oh, yeah. They go, why would you do that? You're going to work on me for free and give me $50 if it doesn't work? Why would you do that? I said, because it's going to work. Everyone cancels their surgery, and then your family's going to be impressed and amazed, and they'll come to me, and I'll take their money. And I only had one person in all my career, unless it was something that truly wasn't carpal tunnel. There was something else going on there, misdiagnosed, which never happens. But we'll talk about that later. But I had one woman, and she got the surgery. And I asked her, I saw her later on, I said, you have a scar. Did you get the surgery? Yeah. I said, well, why? She goes, the doctor felt it'd be best. I said, but weren't you pain-free? Yeah, weren't all your symptoms gone? She said, yeah, but the doctor felt it'd be best. So you can fight against it all you want. The surgeons in my area weren't real happy with me because they kept canceling their surgeries, and they didn't say, you can't fix that. I said, there's no study that proves it. I said, proof is in the result, not in the study. So it's a great technique. I don't charge for it. I do it for free. All of you should be ready to give a speech at any given moment. And I was asked before my Rotary group once to talk, and I gave my introductory speech that I give for this class in about 15 minutes, and I gave a lot of good information. But I mentioned about their false carpal tunnel, and I was talking about this, and I got a phone call from the president that afternoon, and she says, I'm scheduled for surgery. And she had come in, and I worked on her, and I was working and doing the carpal tunnel work, and she's just talking about her son. I'm grinding away, and I said, does this hurt? She goes, no. Anyway, I said, wait, stop. I said, does this hurt? She goes, no. I said, you're scheduled for surgery, right? She goes, yeah. And I said, okay. And I pushed on her pec minor, and she goes, that doesn't hurt. I pushed on her anterior scalene, and she screamed. And I said, I need you to see somebody else. And I gave her a card of another doctor, and that she did not have carpal tunnel. She had something else going on. So there's a lot of misdiagnosis, but if they have carpal tunnel, it will hurt to do this technique. And you got to warn them. It's like resetting a bone. Some things are uncomfortable, but it's really quick. I can treat this person in about 3 to 4 minutes, and they're done. So be aware of that. So we want to let carpal tunnel release. There's 3 steps to this. Now, honestly, there used to be 4. And so remember I mentioned that we don't want to warm up an area that's in acute. Well, if this person is ready for surgery, and they're going to have the surgery done in a few weeks, and it's already inflamed, I don't want to make it worse. So we're not going to warm the area up. We're just going to get in, get it done, and get out. So the first thing we do is we're going to go ahead and stretch these muscles. So if you take the hand and put a palm up and put pressure on those muscles, and you pull the hand back, you get a stretch. But I want to enhance the experience. So we're going to go ahead and we're going to keep the fingertips straight. So I put pressure on here, drop it down with the fingertips straight. It's a lot more intense when I do that. Now, I don't want to work very hard for a living, so I want to have her bring her hand up, put thumb over thumb, drop her hand down, keeping her fingertips straight, drop it all the way down. Fingertips straight. There it is. Come back up. Somewhere else. I don't care where you start. If you start at the elbow or the wrist, just work yourself back and forth. Come up, and we're going to kind of take the pressure off of these structures by elongating the muscles, by giving them some ability to stretch. So up and down, about 30 seconds is all you do. Even 20 seconds is enough. All right? Then we turn the hand over, palm to the floor. Now, I could put pressure on here and drop her hand down. She'll get a stretch. But if she makes a motorcycle gentle fist here and she revs that motorcycle, right? She revs it. And she's going to bring it up and put pressure on there. We're going to drop it down, release, come back up, put pressure, drop it down, release. So I want her to do the work. So I'll put thumb over thumb, drop it down, up and down and up. I don't care. Up and down. All right? The second step is cross-fiber friction. So we have these wrinkles of the wrist right here, unless she Botoxes those, which is, possible. So she's going to take these wrinkles of the wrist, and we're going to work above and below, an inch above those wrinkles and an inch below those wrinkles, and everywhere in between, in every direction. So we're going to go cross fiber, width fiber, diagonal, all the different angles, all the way around, and pretend that your kid comes home with a really, really naughty temporary tattoo on their wrist, and you're just ticked off, and you're going to get that thing off there, right? That's what you're going to do. You're going to rub this thing on here. How dare you? You're going to rub and grind every which direction as though there's a temporary tattoo. Now, there's no ice today, so we're not going to do it for real pressure-wise. 30 seconds, aggressive grinding, really deep. All right? Or there's a piece of gum under the skin. I'm trying to warm the gum up from underneath the skin. So that's what we're going to do, is just dig, 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 and really work through that structure for 30 seconds only. The next part I want to be careful and clear on is this is not an adjustment of the bones. I'm allowed to take any joint through its range of motion, but I'm not allowed to adjust the joint. Am I clear on that? A chiropractor can snap this wrist all he wants. I don't get to, but I can. He can yank my shoulder if he wants, right? That's fine, but I can't. I can take the shoulder through its range of motion. That's fine. So for her, All I'm going to do is take her wrist. I'm going to dangle her wrist on my fingers just like this. Let this hang down there. I'm going to let her dangle it there. I'm going to grip the wrist like a vice. And I'm going to take that wrist and I'm going to rock the bones just like this. Rock, rock, rock. 3 times. 1, 2, 3. I'm going to pinch the bones. And it's going to roll a little bit. And I want to feel movement. Grinding, clicking, popping, whatever. You're going to feel something. Once you feel that, your work is done. All right? If you don't feel that, you go back and do it. So I go 1, 2, 3. I pinch the bones and I roll. Now on her, I felt it. I'm finished. If it doesn't move, I want to do it again. Up to 3 times and then don't do it anymore. Grass doesn't grow on a busy street. So if these bones are stuck, I'm just kind of going through a range of motion. If they're stuck, it allows them to not build up as much adhesive scar tissue if they're moving than if they're stationary and stuck together. So again, I'm not adjusting them. I'm simply taking it rock, 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 pinch the bones, roll through that, looking for movement up to 3 times. If it doesn't work, next time she comes in, I can do it again. All right, then you take an ice pack, and you want to put, if it's a cold pack, the type that are like a smooth, hard finish that transfer cold really quickly, put a paper towel around her or something, wrap the cold pack around her wrist, hold it in place for a bit, let it cool down, check it, make sure it's cold, and then you're done. If not, ice it some more. If it's a little fuzzy pack, some of the, like the soft gel packs that have a fuzzy surface, they transfer that cold slower, so you want to make sure you just do it longer until it stays cold. So, does that make sense? All right, thank you. You can do this work on your own. So when you're healthy, you can do the pin stretch, and you can do all this work on yourself, right? When you have no strength because you have carpal tunnel, walk up to your bar counter at home, your little kitchen, high nook counter, drop your hand over the lip of that, use an elbow to do your stretching, turn it over, elbow, you can grind it. You can't really do the carpal bones, but you can wrap your fingers around it as tight as you can, just roll your hand to get some movement in there. So you can get some movement and do this work on your own. I want to talk about something called the Quervain's Tenosynovitis. What I want you to do is I want to put your hands up, and I want you to put your thumb inside your hands and wrap your fingers around your hand tightly. And I want you to firmly ulnar deviate. Now put your hands down. Put one hand up if that hurt. A lot of people. So what that is that's the Finkelstein maneuver to test for de Quervain's Tenosynovitis. Now I don't want to diagnose somebody, but I want you to realize most massage therapists, because of our very work, are on the brink of Tenosynovitis, or the Quervain's issue. And so all that to say is it's more about how do we treat ourselves with this, because a lot of massage therapists are just under the level, just under that bar of pain where something throws it off. They go out and work all day in the yard, they're throwing their pickaxe, and they're breaking up the clay in the yard or something like I did years ago. And I couldn't work. And as a matter of fact, it gets so tight on some people because you've got 2 tendons sharing a common sheath, is that inflames, it actually makes a tripping sound. Don't laugh at your client when that happens. But remember I mentioned about the foam collar, movement is life, lack of movement is death. Don't wear that, typically is the best idea. That said, people also sleep funky. And we also forget that we shouldn't use our thumbs when we have de Quervain's. The best thing for de Quervain's is not to use your thumbs for a bit, give it a rest, cool it down, ice it, that kind of a thing. So because we don't always pay attention to what we're doing and we sleep funky, we want to make sure we isolate that thumb when we do sleep or when we're doing tasks that require us to use our thumbs so we can retrain our brain. So a doctor is going to give you a prescription for a thumb spica. It's a hard plastic type support that keeps the thumb from moving. And that's really important to wear when you sleep and when you're likely to use your thumb. So if you're a massage therapist and you've got de Quervain's, especially on both sides, you're going to basically want to give somebody an 8-finger massage and use your elbows for about 2 weeks. Leave it alone and do some self work. And the self work I do is basically taking that same exact test, radially deviate, put pressure on the top, and just stretch it out. Do some gentle grinding. Get that area to open, and then ice it back down and cool any inflammation that go with it. And then don't use it. Again, gentle stretching, open the area up, and then ice it down. So it's easy to get. Most massage therapists have overworked the area, and they're likely to have something cause that to go over the edge where it causes their thumbs just to hurt like crazy. So that's the one time where inhibiting movement is going to be a good thing just to keep it from exacerbating. Next, we're going to talk about headaches, and there are many kinds of headaches, but I want to discuss a few with you. The first is the tension headache. I mentioned that person in your life that causes you just to stress out and to grind your teeth and get angry. That's a tension headache, and typically that's going to come, in the jaw. We've got issues with, your masseter or your temporalis, those kinds of things, from a grinding or just general tension overall. So be aware that's going to happen. Also, when that happens, you'll feel, you've got issues in the occiput, the occipital ridge, and occipital headaches. But sometimes you'll get a client who comes to you and says, I've got this pain in my eye. And I remember back when I was in massage school, I was kind of a little overachiever, and I'm reading the Travell's books, and I'm on this page that shows this referred pain pattern of pain in the eyeball. My mom's walking down the hallway at this very moment with her hand over her eye. She goes, oh, my eye is just hurting. And I said, where? And she said, well, just right in the eye. And I looked at my book, and it showed this trigger point. Now, I shaved my head just for you all, just for you. And so here's my occiput, and just above that occipital ridge are two spots on both sides, right above, laterally, that on most people are flat, but if you push on them, they're rather tender. And when you push on those spots, that's your occipitalis. When the occipitalis gets ticked off and gets a trigger point, it puckers. When that thing puckers, you're going to finally feel it. You wouldn't feel it otherwise. And when it puckers, it's going to send pain oftentimes right to the eyeball. So when my mom walked up to me, I poked her in her pucker, right where it hurt, and instantly she said, ow, you made it worse. And so I massaged it, squished it, ischemic pressure, bringing blood to the area. It's like squeezing a sponge and full of paint underwater. You keep squishing it, it's going to start to run clear eventually. So we kind of kept pushing it, bringing fresh blood to the area. Then I put some ice on it, which vasoconstricted, took the ice off, vasodilated even more so, rushed in the area with blood, just relaxed, and her pain went away immediately. That's when I became a true believer in Janet Travell's work. So the referred pain from that muscle will cause eye pain. So the occipitalis, we often call it the occipitofrontalis, and you've got two different muscles connected by the galea epineuritica. It's truly two muscles, but it's guilty by association through that galea epineuritica, and that transfers pain forward and causes headaches and such in the front of the head. The next aspect of headaches really comes down to TMJ, and I got to tell you, temporomandibular joint dysfunction issues are causing more problems than you realize. In my experience, more than half the people that have, quote, migraine headaches have actually just TMJ issues. The referred pain pattern from a TMJ problem mimics a migraine precisely. And so let's talk about the migraine style of TMJ issues. I was flying back from London, and this flight attendant came up to me, and she said, she goes, can I get you anything to drink? And she had that look in her face like she's got a headache. You know that face? And I said, how's your headache? She goes, oh my God, I got a migraine, and it's just killing me. And I said, this is the first question. I said, does your jaw pop? Do you have any issues in your jaw? And she said, yes. The next question I want you to ask is, I said, do your medications work for that? She says, no. So typically when you have a TMJ-based migraine, they have jaw issues, and the medications don't work because they're trying to treat something that doesn't exist. Trying to treat something else, but the referred pain mimics the migraine. And because I was at 37,000 feet over international waters, I said, I'll make you a deal. So I said, if you have a med kit in back, I've got a pair of gloves there's a pair of gloves in the med kit. I will put my hands in your mouth and the outside. I'll massage you for about 5 minutes. And after I'm done, you'll come back to my seat and you'll tell me your headache's gone. She goes, what? I said, 10 minutes. You'll come back and tell me it's gone. She goes, you're on. So they made a wall in the 747 of flight attendants, about 8 of them because it's the big one on the 747. And I'm back there and I got my hands in her mouth and I'm working on her. And I said, okay, you're done. I went back to my seat, and about 10 minutes later, she goes, oh my God, how'd you do that? I said, it's not rocket science. It's just relieving the pressure that's referring from your jaw stress, and that's causing your headache. So when a client comes to you and says, I have a migraine, if they come to you at all during that phase, because typically you don't want to be touched, but you want to ask those questions. And if they have a migraine, then that it does not work from the drugs, and they have jaw issues, deal with that. Don't do anything else, just deal with that, and you'll find you have a better response. The next kind of true migraine, from my perspective, there's many types of migraines, but one of the most common ones I've found is from a lack of circulation, a lack of ability for blood to leave the brain, to have a positive pressure. So you have a heart right here, pumping blood all the way to the brain. It gets into your brain just fine, but how does the blood get back out? Well, it has to drain out. So there's this movie called Mr. and Mrs. Smith with Brad Pitt and Angelina Jolie, and he's in counseling. He's talking about his wife. He says, I love my wife, but sometimes I just want to... And that's like freeze the frame in the movie, but he wants to squish your neck, and that's a migraine. So what happens is when you have tension in your neck, you've got so much tension, it's blocking blood flow. Blood gets through that tension, okay, but how does it get back out? Well, it's supposed to drain. But if it's inhibited, that causes a positive pressure in the brain, which causes the migraines, the starburst headaches, and those kinds of things. And so by releasing that, we're going to be able to help the person out. The problem is when someone's got a migraine, they want to be in a dark room where it's quiet and left alone. You don't get a chance to work on them. So when they get to the point where they're literally or suicidal, I've had people call me up and say, I'd rather be dead than deal with one more day of this pain. Find a way to get them into your office, preferably have someone drive them, and be prepared with a hydrotherapy solution. We're not going to be using a massage. We want to get the area to open up, and to do that, we use hydrotherapy hot packs. So we're going to use something called convulsive fluxion. So you have two buckets. You have hot water, not scalding, in one bucket, and you got ice water in the other with ice cubes floating. You get two hand towels. So we're going to go ahead and take that one hand towel. We're going to wring it out, wrap it all the way around their neck for 3 minutes. We're going to follow that with ice cold towel for 1 minute. I don't want to take the hot towel off, take my time and put the cold on. I want to shock it as fast as I can. So the heat comes off, boom, the cold's on as fast as possible, and I want to shock it. Why do I do that? Well, I'm going to do it 3 times. The first time is the vasodilate. Second time, vasoconstriction. The next time, these are muscles that control these vessels, right? We're going to super vasodilate, cold again, vasoconstriction. The third time at hypervasodilate, these are all important words to use. It hypervasodilates, my term. And by the time you put cold, the next time you cool it back down, it constricts. When you get done, the body says, dang it, I'm cold. Woof, and blood starts to flow. And it allows the tension to come out of the muscles, which allows the blood to flow out of the brain, and the migraine literally just starts to settle down. Now, the question is, the chicken or the egg question is, why is the neck tight? If it's tight because it's bracing itself to protect from a fixation, a chiropractor needs to get that mobilized. So I want to do it. Ideally, I want that person to be able to see a chiropractor within 30 minutes of me doing the hydrotherapy. So I'll call a chiropractor up, say, I've got somebody on the table. I need you to squeeze them in really quick. It's important. They've got a migraine. I'm going to loosen the area up. I'm going to get some hydrotherapy going, get the area moving, but I want you to double check it. Because if something's going on, if there's a fixation, the muscles will seize again, causing the very problem they're dealing with. So you want to make sure you deal with that and get the area moving. Again, movement is life. Lack of movement is death. Get that area moving and the migraine will stay gone. Otherwise, it'll cinch back up and the migraine will return. The next kind of headache we typically deal with is like a sinus headache, and you learn in school, it's pretty simple stuff. You want to massage the little divots where the sinus drains, work those out. That's pretty easy. But what mimics a sinus headache is when someone goes off of coffee. Now, when you go off coffee and go off of caffeine in general, it can cause up to a 5 and 7 day headache that mimics a sinus headache. So here's the important thing. Coffee is the nectar of the gods. Never, ever stop drinking coffee. It's really important. Am I right? Yeah? Okay, so coffee is, I'm just kidding. So the point is that when they go off of caffeine, it will mimic, because every single time they get that sinus headache, they're out at the drugstore buying themselves sinus medications, and the truth is it's just an issue that makes it mimic a sinus headache. The next thing is hormones. I don't want to get off into the politics of this, but literally drug companies are trying to take away your right to having natural hormones, and it's becoming a political issue. It's easy to get a patent on something that's not natural. You know, your receptor sites, ladies, for your hormones are human. And when you take a pregnant horse and make it chemically pregnant and cause that to give urine out, and they make pregnant mare's urine or Premarin, and you take that pill, those hormones do not fit the receptor sites properly, which can cause disease. Now, I don't want to get sued by saying this, but I don't care. My point is that the receptor sites on that don't match, and there's going to be problems from that. So if you want to have natural replicated hormones that are identical to humans, go to a compounding pharmacist and get those. But the idea of taking something that's made for a horse, not as good, but that can also give headaches if you're chemically imbalanced from a hormone standpoint. So see a naturopath, work with a compounding pharmacist that can help you out in that regard. Next is blood sugar. Eat something. Any questions on that? So when someone comes in to see you, oh my God, a headache, I'll ask them, when did you last eat? Oh, I forgot breakfast, right? So those are often simple. But I want to talk about the one last thing on headaches that's really, really important, and that is the enduring headache. And you can actually save a life with this. If a patient comes to you and they say, I've had a headache for 3 days. Now, I don't mean they've had a headache for 6 hours, it's gone for 20 minutes, it's back for 2 hours, it's gone for 5. It never goes away for 3 days. It's a very intense headache. They need to go see a doctor immediately. They need to have a brain scan done and be told there's nothing wrong before I will massage them. I had a patient, not a patient, I was driving back from Texas. I had come teaching a seminar in Dallas and caught a taxi, and we're driving back to the airport, and the taxi driver shaved his head just like myself, and he had a flap cut in the back of his head. And I said, aneurysm or tumor? And he goes, aneurysm. How'd you know? I said, well, I teach this stuff. I said, tell me what happened. He said, well, I had this headache. I said, how long did it last? He goes, well, about 3 days. I said, okay, what happened? He goes, well, my sister said we're taking you to the hospital. He goes, no, I'm fine. She goes, we're going to the hospital. So they went to the hospital, and they did the scan. They said, oh, you're fine. And sister said, like heck. And so she took them to a different hospital, which found the problem, which was an aneurysm. So 3 days, if that thing bursts and they die because you're like, well, let's try this new technique I learned. No, have that excluded as a possibility before you move forward. There are cases, now you cannot diagnose. You can also, but you can suggest. And if so, you'd say, well, ask your doctor about this just to make sure that's not a possibility. If you're a middle-aged woman, slightly overweight, there's something called pseudotumor cerebri, which is an increased pressure in the cerebrospinal fluid, and the body does not know how to balance that back out again. They will actually put a needle in the spinal cord and check. This little ball will float, and they'll see how much pressure is in there. So if it's too much, they can actually drain that down. The body should reset and take that headache away. Some people, I actually had a lady in my Olympia class a while back, and she said that she has to have hers drained monthly. So it's just a very rare, odd thing. But if they have a 3-day headache that never goes away, which means it's more than 3 and keeps going, and they say that she's crazy, she's got no problems in the head, it could be that issue, but that's fairly rare. On the headache issue, the hydrotherapy work, it can be done on your own. I had a woman once who took the class. She goes home, her friend says, oh, my son's off in Iraq, he's got this migraine. She said, oh, well, get some hot water and some ice water. And so she tells her friend how to do it. Her friend tells her son how to do it. And the son does it to himself, and his headache goes away. And they're like, oh my gosh, how does this work? So it's not rocket science. You don't need a therapist to do this. So you can teach your clients to do it in a seated position. But again, the biggest thing is quickly change from hot to cold and don't delay that piece. Let's talk about cervicals really quick. If you've ever seen somebody with a lack of curve in the cervical spine, so they actually have a straight military neck. As a massage therapist, we're typically trained to do work at the occiput. We're typically trained to do scaling work and SCM, but the deeper work isn't as much of most people's training, so we want to include that. And the reason is when someone has lost their curve, it's typically the deep muscles of the cervical spine. So you want to make sure you're actually working what we're going to teach and how you move the trachea aside and are able to work on those muscles specifically. So the longus capitis, longus coli muscles, when those cinch down, it brings it into a military neck. Now, my belief system, I love chiropractors, I have chiropractors as friends, but my philosophy on this muscle is massage is a nicer way to get that curve to return with chiropractic use. But if that muscle is locked down and they're whipping on the neck and actually causing that muscle to snap, and that causes it to relax, that works. But if I can massage it and soften the muscle and lengthen it, and that brings the curve back by itself, it's just more nicer for my style of work. So they both work, but that's the muscle that tightens up that causes that loss of curve in the cervical spine. So be aware of that, and we'll be able to help your clients. So there's 3 places where we've got thoracic outlet running through. It goes possibly through the brachial passes between the anterior and middle scalene. So when the anterior scalene is tight, typically we can know there's a thoracic outlet issue going on. Am I going to tell them they have thoracic outlet? No, but I will treat them for that. Second place is between the clavicle, your collarbone, and the first rib. It goes under there and causes that actually to pinch. Another aspect of thoracic outlet syndrome we need to be aware of is how implants, subpecular implants, can affect thoracic outlet and cause thoracic outlet issues. So when you have breast implants put in the body, they typically are going to be either over the pec major or under pec major. When they put them under the pectoralis major, they actually make them into the pec major into a sling, which holds that bag. Because pec major mounts to the clavicle, the collarbone, it's going to be pulling down on that with weight. So when a woman has over about 350 cc's in that bag, that weight coming down typically is going to possibly cause a compression. Now, let's say that same woman gets in a car accident. Now she's got tight anterior middle scalenes pulling up on the first rib. Implant is pulling down on the clavicle. You're going to have compression. So what you can do is actually lengthen and work on pec major, work on lengthening the anterior middle scalene, get pressure off that nerve, and help that condition. So it's more common than you think, but make sure you're dealing with both of those at the same time. The third compression is pec minor. We'll show you some techniques to lengthen that and to get pressure off as well. A couple things before you go into the neck deeply is to keep in mind is one is you have the thyroid gland. You don't want to squish it. So that Adam's apple, the hyoid bone, I typically don't want to work below that. You can touch the thyroid. You just don't want to put pressure on there and move the esophagus and trachea because of that pressure on the glands. Just be aware of that when you're working. You want to make sure also that you're aware of the pulse. Now, in school you're told, well, if you feel a pulse, move. No. If you feel a pulse, don't squish it. So if I'm putting my fingers in the anterior neck and working and I feel a pulse next to my fingers, that's fine. There should be a pulse or else they're dead, right? But if I'm squishing that pulse, that's not a good idea. And the reason is we have this condition called the carotid sinus. And so it's not a condition, but it's able to measure your body's blood pressure. And so when you have this mechanism in the carotid sinus that's able to measure blood pressure, that's a nifty deal. But if I put pressure directly on that and the body goes, uh-oh, our pressure's increased, we got to drop the whole body's blood pressure, well, the person will pass out. Thank goodness they're on your table, when this happens. But when you go on there and you squish that, you can cause your client to pass out. Not always, don't freak out, but just make sure that you're not squishing the pulse, you're next to the pulse. Does that make sense? So watch out for that. Piriformis syndrome is what I affectionately want to call it, lawyer's ass. When someone's got deep lateral rotators that are pulling their feet out into a duck type position, which isn't fair because ducks actually go forward, but we just say it. But when we have that issue going on, obviously we got more than one deep lateral rotator involved. We blame the superficial one. The reason we blame it is because out of all those deep lateral rotators, the top one, the piriformis, is where that nerve comes under and it gets squished. And so when that gets squished, because we get this radiating pain down our legs, and we get what's called false sciatica. In all of my years, I've seen very, very, very few cases of real sciatica where the nerve is being pinched in the lumbar spine. Most cases have been a muscle pinch. And I actually had a lady, she came into me once and she was I'm just de-stressed. I'm just stressed out. I need a massage. I said, what are you stressed out about? She said, well, I'm scheduled for having this surgery in my back. And I said, what kind of surgery? Well, it's for sciatica. And as I'm talking to her, I'm kind of glancing down at her feet. And of course, her feet are out. And I would never tell a surgeon he's wrong much. And so she came to me and I said, well, tell you what, I'm going to work on you, but I want to show you a stretch that I want you to do 3 times a day for 30 seconds aside every day between now and her surgery, which is 10 days away. So I want you to set your phone, because with smartphones you can make little alarms like, when to get up, but you also have alarms that say, call your honey and say, I love you. And you can make any kind of stretch type of alarm you want too. And I said 3 times a day, I want you to stop whatever you're doing, sit down and put your knee over the opposite leg and up to the opposite shoulder. And I want you to stretch this out. And that stretches in your book. And so I had her do this 3 times a day. About 7 days later, she called me up and she said, I'm out of pain. What did you do? And I said, well, I didn't do anything. She goes, was I misdiagnosed? I said, I would never say that out loud. And so I said, I want you to see another doctor. And sure enough, she did not have sciatica. And so this stretch is really, really helpful. Now, if she has true sciatica, it's going to hurt the low back a bit to do the stretch anyway, but you're going to have some pain when you impinge the very same nerve you're trying to let go of. So this is one of the few things we do. We have to make worse to make it better. So to elongate that muscle, get some pressure off of it, you just stretch it out and be consistent. And when you get the pressure off the nerve, it allows it to function better. Now that nerve really is big, and it has 2 branches to it. When you look at this model, which is funny to me, is they have this little sciatic nerve right here that's flat as a ribbon. You see that? Any idea why it's flat as a ribbon? Because it was dead in a body bag for 5 years before they cut it open. They said, oh, look, it's flat. Guess what? It's big. And so that nerve gets impinged, and you want to make sure you understand that it's a big nerve you're dealing with, and it's easily impinged if you've got something tight affecting that. In your book, you'll notice there are some deviations to what's supposed to happen. There's different parts of the population have a different type of deviation, but mostly people have the nerve going under the piriformis and over the other lateral rotators. Sometimes, against that, the nerve has 2 bellies. Sometimes one belly goes over the piriformis and one belly goes under. Not the best idea. Sometimes they can both go over, and sometimes they can go through the muscle belly itself. So you might have one strand of the nerve going through the actual piriformis, and even worst case, you have the entire nerve going through the belly. And so you can't fix that. But all you can do is make sure the nerve is helped out by having the muscle as long and as stretched out as possible, so it's not going to tighten up as much on them. So stretching is going to be very helpful for them. So I want you guys to go ahead and stand up, and I want you to look at your feet. You can take your socks off if you like. You can leave them on. But look at the toe next to your big toe. I'm going to ask you in a few moments, is the toe next to your big toe as long as or longer than your big toe? So if it happens on one foot or both, I don't care. As long as it happens on one foot, you have a toe next to your big toe is as long as or longer than. So raise your hand if the toe next to your big toe is as long as or longer than your big toe. But what you'll notice is about half to 60% of the U.S. population has this, and it's called Morton's toe or Morton's foot structure. What does that mean? Well, we're not blaming the toe. The toe is just showing there's a problem in the actual formation at that moment of your foot bones, and it's not where it's supposed to be, which forces that second toe out further. When you've got those issues, you have that structure, it actually causes you to hyperpronate. When you hyperpronate, your knees come together. I'm going to exaggerate that quite a bit. Your knees come together and it causes stress on your glute medius and minimus. So if I were to ask you, of all of those who have the Morton's foot structure, how many of you have been dealing with hip issues most of your adult life? About half of you would raise your hands. So when you have a client who comes to you with hip issues, the first thing you want to do is have them look at their feet, take their shoes off, look down at their feet, and see, is the toe next to the big toe as long as or longer, at least on one foot? If it is, you need to go to a podiatrist, deal with that foot structure, and then deal with the muscles. Now, you still, of course, can massage them that day and work with it, but you're only going to be giving palliative care. It's not going to be curative until you deal with that orthotic issue that needs to be done to build up. Now, you can do simple things. You put pads behind that toe, and there's other things online you can look up at ways to take care of it, but really they should deal with a good orthotic to help that out. So deal with that. That's really causing the hip issue. The hip issue is not the issue. It's resulting from the foot structure itself. So we're going to treat gluteus medius and minimus, and I'm going to show you, I can talk you through it, but I'm going to actually show you the trigger points on this. And if you look at the screen, you're going to see just the glute minimus alone. You've got one muscle on top of the other, and the minimus is the lower muscle. And there are so many trigger points, it's not even funny. So on the screen, you're going to see two legs because they want to break it down. But the pain that can refer from the glute minimus trigger points is pretty distant. It goes pretty far from the local area, and that goes on the glute max itself. You're going to see pain down the IT band, the lateral knee, the lateral gastrocnemius, the pronatus muscles, clear down the lateral malleoli. Other trigger points there can cause pain down the back, the biceps femoris. It can cause pain down the popliteal fossa area as well as the gastrocnemius itself, the whole belly. The glute medius, which lies on top of this, and of course you're looking at muscles that are one on top of the other on the hip, are more localized for the medius. And that's going to be referred pain pattern on the glute itself, along the iliac crest, and the sacral area as well. So you're going to see a real localized referred pattern, but when someone has any issues down here, any issues of the hip and leg or referred pain, just do the glute medius and minimus. It's like shooting fish in a rain barrel, man. You're gonna, everywhere you push on those muscles, you will find the trigger point. I'm going to get on my soapbox for a few moments on body work and treating what is comfortable. You know, I get frustrated in my field when I see massage therapists not treating what they don't like to have massaged themselves. And they come to our field with their own issues and they perpetuate those issues onto their clients, and they compromise their clients' ability to get well because they have their own stuff. So, an example, if you don't like to have your stomach worked on or your pecs worked on, you don't work on your client's pecs, or you assume they have the same issue as you do. So if you have a client who's got low back issues and they won't let you work through their abdominal wall to work on their psoas, you're not going to get them well. You can massage the abused muscle all you want, but until you deal with that, you can't get them well. So if they come to you and say, well, I just don't want you touching my stomach, talk to them about it. Find out what's going on. But if you have your own issues and you won't do it, that's not okay. If I go to a brain surgeon and he says, I have good news and bad news. And I say, what's that? He says, well, he goes, you got a tumor on both sides of your brain. You got two tumors. The good news is I can get the one out of the right. Whew, that's going to be great. Bad news is, you got one on the left too. And I just don't feel comfortable with the left side. So I'm just going to leave that one in. You're going to die. But I feel so much better for myself. So we skip areas of the body because it makes us feel better about it. And we're causing a person not to get well because of our stuff. If you have issues, go get counseling. And if you don't want to get counseling and you don't want to deal with it, get out of the profession. You should not be treating people because you're not comfortable with something. If they need it and you don't offer that, and you have the ability, you're hurting your client. It'd be like having a medical kit and the person needs something. You're like, no, I just don't want to give that to you. Well, then don't be a paramedic, right? So deal with your stuff and give the client the help that they need, and don't be afraid. And the best thing actually is education. If you can educate your client on the areas they feel uncomfortable with, they're much more likely to let you do. Now, like I said, if I have a client, I say, I'm going to work on your chest, but I haven't explained why I need to do that. They're much more apprehensive. I want to touch their upper pectoralis region until I say why, and they go, oh, I get it, right? So education is often important, and sometimes it's just desensitization. I had a lady who came in, and she said, I never want you to touch my stomach. And I said, why is that? She goes, I just don't like it. I said, I'll make you a deal. I'm going to add 5 minutes to your massage today. I'm going to put one hand under your back and one hand on top. I'm just going to hold it. You leave your clothes on if you want. I'm just going to wait and just talk about 5 minutes. Talk about your kids. Talk about their, what's going on at home and where you're going on vacation this next year. And after 5 minutes, we'll be done. And Next time you come in, I'll do the same thing. I'll add 5 minutes to your treatment. We'll just do that. After the first time I did it, she goes, oh, that's okay. Go ahead. She was fine. She just didn't realize that that actually could be a comforting thing versus just, and sometimes it's a visual thing. They say, I had a lady once, it sounds absolutely insane to a guy especially. She goes, oh, I don't care if you see my boobs. It's my stomach I don't want you to see. And I'm thinking, what? And so the people's body perceptions and what they're embarrassed about and their stretch marks or whatever the case is, whatever they're dealing with, find a way to work with them that makes them feel comfortable, but don't ignore a part of the body because it makes you happy. So make sure you educate them and work with them within their tolerance, but also don't perpetuate their problem by only working half the issue. The iliotibial band looks like it is a structural, tendon off of the glute max, when in reality it's a strap, and it's a structural strap to hold the thigh in place and hold things together. You have a lot of really powerful muscles wrapped around that puppy, and that strap really helps. In reality, though, that band can become problematic. I remember working in a health club years ago, and these guys would stand around these big, humongous chests and biceps, and they're just huge, and they stand there like, ugh, and these little skinny little chicken legs, no calves, and all they have is one dent. And they're so proud of their IT band indentation. Look at that. It's like, that's not a muscle. The problem is what happens when that strap that's on there gets stuck. Well, that strap, when it gets stuck, the underlying tissues no longer move. And our muscles are meant to glide past each other. But when the muscles get stuck to that strap, there's a problem. As you sit in your chairs today, you are squishing fluids out of your posterior thigh, right? Your hamstring area, your biceps femoris. And you're squishing fluids out of your mid-back, which creates glue. Write that down. It's a technical term. Right? So we're squishing fluids out, creating this stuck adhesive glue, and that's problematic because muscles that used to glide past each other now really can't. So when you have an IT band, very broad, sticking to the underlying muscle tissue, and I want to move and run, and I'm suddenly inhibited somewhat, I'm having to work harder to get my body to move where I want it to go. In the Northwest, a lot of us work with bicyclists. And if you're a bicyclist, I used to ride my bike 25 miles every morning, and then life happened and I got older, but I used to ride 25 miles every morning, and I was learning about bicycling, and I would watch people on their bicycles, and if you look at them from the air, it looks like this oftentimes, and they're driving kind of in like an S shape, and the problem with that is that's a slow arrow. If you're an arrow, you want to go straight through the air, not wobble through. And so bicyclists will practice on this thing called a bicycle trainer, which we'll show on the screen. And the bicycle trainer is this mechanism that has these two barrels for the back tire to roll between, and then one barrel for the front tire to balance on top of. The nice thing about the bicycle trainer is that every mistake you make, you fly off that sucker, and you land on the floor, and you get back up, and you do it again. It's not like the ones you think of back when you were a kid and hold your back tire off the ground for exercise. This is a mechanism to help you with balance. Once you master that, when you're on the concrete, you're straight as an arrow. You're not wasting any energy. To do that, though, if you watch on the screen, you watch the bicyclist use that mechanism, that the knees end up wobbling and end up looking like this piston system, and that allows the bike to go straight, but the balance comes from that movement. If that balance is inhibited by the IT band being stuck, it makes it harder to work. And if you're on a 110-mile bike ride, if you're doing some kind of a sport of some sort, and that's making you have to work a lot harder. So we want to get a shear action to pull that muscle away from the IT band, get some range of motion in there, and allow the person to function without being inhibited. So we're going to show a technique to really undo that strap. Shin splints are a frustration. Anybody had shin splints before? They hurt like crazy. You ever heard of less is required, so less is given? Well, it kind of is true with the body. If you look at, let's just say that all I have that holds, lifting something up is my biceps brachii. Let's just say that's all I've got to do that. So let's simplify our anatomy for a second. And the biceps brachii has two connection points. So if I want to hold a 200-pound person in my arms, just statically holding them, I've got about 50 pounds per connection point on that shoulder girdle, right? Yes, there's more that are involved. I'm just saying, let's just do some simple math. And that connection point is about this big, about a 1/4 inch square-ish of actual tendinous connection. So that quarter inch being 50 pounds of strength, all right? So I know you guys were told there'd be no math today. If you look at the tibialis anterior connection, it's pretty huge. And in that space, I can fit hundreds of those quarter inches, right? Well, that equates to thousands and thousands of pounds of strength. I don't need thousands and thousands of pounds of strength, so I don't have thousands and thousands of pounds of strength. So it's actually a very, very weak connection. And so when I'm a runner and I don't warm up and I run downhill, not warmed up, especially with bad shoes, and my foot has to extend further than the flatness of the ground, but actually downhill, my tibialis anterior is pulling away from the tibia with each strike. And if I have a hard-heeled shoe and I'm running in a pair of rented tuck shoes downhill on hard concrete in the cold winter away from my wedding, I deserve to get shin splints. But if I have that hard strike point on that ground, pulling even further as I go downhill, that pulls that muscle from the bone. So the technique we're going to learn basically is to squish that back in. It's a pin and stretch. In other words, just trying to get some movement, trying to get the ischemic pressure and squishing that tendinous connection back, or that aspect of the muscle tendon into the bone. It's a very short tendon. So how many muscles in the body connect to bone? None. Tendons connect to bone. Trick question. So it's a very short tendon, but that tendonous connection yanks away, and so we want to squish it back on and do a self-treatment that allows that to stretch out again and get some more range of motion, so it helps it speed along. So when we walk, we are dealing with a strike point of the shoe onto the ground, right? And so I want to exaggerate. So in your mind, think of me now with a pair of shoes, and I'm going to take a piece of wood that's about 6 inches longer than my foot, and I'm going to make it flush with my toes. I'm going to stand on top of that board and wrap some duct tape around my foot in that board. And when I walk, the back of that board is behind me, and if I step, it's going to flop my foot forward, right? It's going to make me launch forward as I walk. Well, when you have a shoe with a flat back to that shoe, or even slightly extended backwards, as I step, it yanks my foot forward with each step, and it actually pulls harder on my tibialis anterior away from the tibia. The reverse is also true. If that strike point of my shoe is moved forward directly beneath the bone of my leg, you put it below that, it allows that to be more of a roll. So if you can look at like a roper cowboy boot where the back of the cowboy boot is moved forward, it allows the strike point to be directly beneath my leg versus beneath the back of my heel. And so instead of making my foot flop and tear each time I walk, it allows more of a roll. So I get more Texan style. How you doing, right? So it allows that foot to roll and reduce that strike point on the ground. So shoes, you women, you wear pumps. Where is the heel? Well, it's moved forward. How do I know this? I have 3 daughters. So I watch that strike point move forward. It's better for the foot. You have a man's logger type boot that has a 2-inch heel on it and it's flush with the back of the boot, well, that's going to cause him to whip more. If he has to run downhill while he's out there logging and that strike point is flat, it's going to actually cause his leg to have more issues than if it was wedged. If I had that job, I would take a knife out and start to whittle away at the back of my heel to move the strike point forward. So oftentimes our shoes are going to make a difference. Another thing with shin splints is you want to watch is the runners. How do they run? Now, I'm not a running specialist, I'm not a running coach, but you should meet someone where you live. So find out, talk to a local sports team, get a running coach, because if your client's dealing with problems in the shins and the hips and the legs and they're a runner, have them run around the parking lot for you. And if you watch them run, they should land with about 60% of their weight on the forefoot. If they're laying, now you walk, that's fine to walk on your heel to toe, but when you run, you do not land on your heels. It's going to cause issues. So if they're a heel runner, they need to get some help. So unless you're a good running coach, find one and refer them to them to get that taken care of. Also, when someone paint on their big toe, when they're painting that on, there's one major trigger point about 1/3 the way down from the tibialis anterior, and there's a trigger point on a lot of folks that they have right at that spot, and it will go down to the big toe, and they can't quite put their finger on it, but they'll brush it and they'll paint it on. So look for that. When they have that painted pain, they go, it kind of hurts my big toe. Look for the trigger point in the tibialis anterior. It's pretty common. 2 more techniques we've added recently to the program is on quadriceps work. You're dealing with people who have difficulties and tension in there. My biggest concern with quads, we're going to show you a nice way to pin, stretch, and make those move more efficiently. But when they don't have that movement and it's imbalanced and spasm, oftentimes it'll cause patellar tracking issues. Long term, that's going to be a problem and cause bone deformity. So just make sure that you've got a really healthy quad that's working and functioning, and that allows that patella to actually work through the groove properly versus being pulled to either side. We're also going to show you about the biceps femoris, which you guys might call a hamstring. I just hate the thought of cutting a pig and hanging it on a hook, so I don't like hamstring per se. But the idea of a tight hamstring is that we've got someone sitting on their butt a lot in their jobs, and it's often men, is that they're sitting there and that forces out the fluids and causes the glue. And so those adhesions cause other issues. If you've ever seen a man, older man usually, who looks like this, it's because of hamstrings. So when my hamstrings are tight, it rotates my pelvis back, and then my torso has to come forward to compensate. It's a secondary issue. And then I got my glasses on, so I got to be able to see, and I got to tilt my head up and deal with the hamstrings. It all comes from back there. So deal with that. Don't think, oh, he's got some, kyphosis, and right. So deal with that. Work with the hamstrings. Get those moving. Then deal with the reactionary aspects of the hip and the low back and the mid back and the neck and everything else. How many here have had plantar fasciitis? Hurts like heck, doesn't it? So when you have this fire, this fascia that ignites in the bottom of your foot, it's crazy painful. And let's talk about that a bit. I was back in college, and back when I was in school many years ago, we had these things called Sperry topsiders, and they're actually back in style again. They're these boat shoes that are a moccasin that have a white rubber bottom and a leather top that's actually hand sewn, and they look really cool. And of course, because they're cool, I had to wear them every day in the summertime. And so I wore them every day. I could only afford one pair. My rich friends could afford the powder blue and the pink and the green. Of course, it was the 80s, so. But these shoes were really cool, and I wore them every day. And after about a month, my right heel started to hurt a little bit. And about a week later, it started to hurt some more. And about a week after that, suddenly I'm starting to favor my foot. And then a week after that, I was limping. I thought, oh, dear God, really? So I went to my doctor, and I said, my foot's just killing me. He looks down at my feet, and he asked me a question that I've asked many clients since as a therapist, and that is, wear those same shoes every day, do you? I said, yeah. He says, let me see your shoe. And I hand him the shoe. He goes, you see that seam that's inside? I said, yeah. He goes, you see that little tiny little knot at the very bottom? I said, yeah. He goes, that's your problem. I said, I'm not a wuss. He says, no. That little irritation every single day, irritating your foot, causes the bone to grow back against that. And it's creating a heel spur. He says, you need to mix it up. Every single day, your foot needs a different impetus, a different input irritation, whatever you want to call it, on your foot. You need to have that difference so your foot doesn't try to adapt to a constant regularity and create that heel spur. So the heel spur is not plantar fasciitis, but plantar fasciitis can come oftentimes from the heel spur, and the heel spur they can both cause each other. So if you have tight plantar fasciitis, you have fascia that's just ignited, it's tightened up, and it's pulling on the bone, the calcaneus bone, a heel spur can grow and respond to that. But a heel spur can ignite the fascia into inflammation as well. So they kind of often are both there simultaneously. So how do you get that to go away? Well, it's one of the things that I say you have to make worse to make better, and that is to stretch out the fascia of the foot, elongate the tissues, make them move, and then deal with the inflammation as well. But get them moving. We actually use a ball, we call it affectionately Bob's Ball of Pain, and we stand on that ball and stretch out the fascia, and there's some actually manual techniques that we'll show you with knuckles and elbow as well, but you want to lengthen those tissues. But how do you prevent that, and how do you make it go away? Well, on a healthy person who's not 85, 95 years old, when you're a healthy person, your body's functioning normally, with enough hydration, enough calcium, which sounds odd, you can reabsorb your bone as long as the irritation goes away. So let's say you're working in a very expensive $600 pair of steel-toed, steel-shank boots, and you can't afford 2 pair of boots. You want to change the impetus in that shoe and the irritation. So maybe one day you're going to wear a pair of Dr. Scholl's insoles. Next day you're going to wear a pair of hiking socks. Next day you're going to wear your orthotic. You want to change up the feel so your foot never feels the same sensation 2 days in a row. That's a cheaper way than buying multiple pairs of boots. That's really important. But to help it absorb, a doctor will often refer you to or tell you to buy what's called a heel cup. And that heel cup, when you're standing and looking at your shoe or your heel naked, oh, look how pretty my heel is, right? When you're standing on the floor with no shoes on, barefoot, from behind you have an elephant's foot. that fat pad goes and squishes outward, and it's protecting the calcaneus bone. The heel cup squishes that fat pad together, doubles your own fat pad, doubles the thickness of protection, and allows the bone to reabsorb from lack of irritation. So the heel cup's really good. Also, if you have plantar fasciitis, the worst time of day is the morning. You get out of bed in the morning, you step on there, and it just burns as you step on that. So all night long, you didn't realize this, but all of you sleep like ballet dancers. Didn't know that, did you? So as you lay there in bed, your toes are pointing. And so you're shortening your plantar fascia all night long. You step out of bed in the morning, and it just tears it out. So to keep that from happening, you can get something called a plantar fasciitis boot. They're very attractive. And so basically, it's a boot that holds your foot in place, and they've got one by a couple of different companies. They're more rugged styles, and they've got ones that are more of a soft material with a strap. But if you can't afford that, you always can use duct tape and a sock. Just kidding. Anyway, the point is you want to stretch out that fascia all night, so the first thing in the morning when you stand on the ground, that's going to make a difference. So when a doctor says to get a bottle of water and to freeze it and to roll your foot over that, it's a great idea, but if you do it and you freeze your foot into place, when you roll your foot over a bottle of water, you're really shortening that plantar fascia. So you're actually shortening it into a shortened, or you're freezing it into a shortened position, then you stand on it, tear it out again. So if you're going to do that, it's a great idea. Put the kids to bed, brush your teeth, get a drink of water, go pee. Sit in the edge of your bed, roll your feet on the bottle, and then lay back and go to sleep. If you need to walk on your feet, try to wait at least a half an hour to allow that foot to warm back up naturally and allows that to get better, natural temperature before you walk on it. That's a good technique. It helps quite a bit. Let's talk about bunions. Bunions are essentially when the big toe is being forced laterally and it pushes itself into the other toes. So people say, I have bunions in my family. It's part of my DNA. I hereditarily have bunions. I disagree. I do agree that grandma had them and that mom had them and you have them, but I don't think that's hereditary. I think what's hereditary is the weakness in the joint and the propensity of having a bunion. So I have bizarre bones. My bones don't break. I've cracked one once when I jumped down 12 feet onto concrete, but I've never broken a bone. I have really strong bones. I use my hands completely incorrectly. I've been doing a lot of massage for a long, long time, and my thumb looks normal. Most people that do what I do and using my thumb like I do should have a bent back thumb. It should bend it backwards. And you've probably seen that before. Older therapists sometimes have a thumb bending backwards because they're using it incorrectly. My bones are super strong. My mom is the same. She's 80 years old on this next year. She's never broken a bone. She's fallen, and she should have, but she's never had. So I have a strong bone. So I don't have a propensity for bone breakage. So people who have weak joints hereditarily have a propensity for those joints to migrate. So I think when someone hereditarily has a weak joint that has a propensity for bending, it doesn't take much to make it move. Same as with braces on teeth. Some people's teeth just move easy, and some takes a lot of work to get those teeth to move through an orthodontist. So when you put shoes on people, that's when bunions kind of begin. I don't know of anybody who's never worn shoes that gets bunions. But that small amount of pressure on some people allows that toe to migrate. Now the question is, what do you do with it once it's migrated? Well, if it's in the early stages, it's just starting to migrate. I love those toe stretchers. You sit at home at night when you're watching TV, put them on, reading a book, put them on, go to bed, wear them. Keeps your toes going forward. They have sandals you can get with little posts between that keep your toes going forward. But when it's gone so far that literally it's changed the structure of the foot, the bones have bent and caused some serious problem, it's one of the few surgeries I recommend having done if there's no pain. I'm sorry, if there's pain. If there's no pain and your feet just look ugly, leave them alone. Okay? I'm really saddened by the fact that one of the newest surgeries being done out there is shortening the second toe. So women who have, Morton's foot structure, they want to have all their toes lined up in their cool open-toed shoes or having the second toe shortened. That doesn't fix Morton toes problem because that's still actually in the structure of the foot itself. But they're shortening these toes, and so it's not a good idea. So if your bunions are causing you pain and discomfort, look into surgery. But if they're not, they just don't look good, leave them alone. Don't break it, all right? So. When someone says, oh, my patient has kyphosis, what does that mean? Well, to me, it's a little bit, it means there's an osis with the kyphotic curve. There's a problem with it. So you could assume that always means there's too much curve, but I prefer when someone says, now I'm not diagnosing, but I want to have someone clarify. They have the appearance of hyperkyphosis or hypokyphosis. So So hyperkyphosis is too much of a curve. So if their kyphotic curve in the back is too much, you can have facet on facet, bone on bone. They step off a curve wrong, and they're already bent. Like they step off, and there's a possible damage to the joint. But the reason we have a spring for a back, we have this lordotic curves and we have the kyphotic curve, is to allow us to have a nice spring, right? And so when you have too much, that it puts too much stress in the back. That's why in scoliotic curves they want to put Harrington rods in to protect from too much and having it go awry. And hypokyphosis, a lack of curve, is also just as dangerous. If I have hypokyphosis, that's too little curve, or almost a straight stick for a spine. And why is that bad? Well, if I have a straight stick for a spine, I step off a curve, excuse the fat jiggling you're going to see, but I step off and there's this impact, it's going to damage the joint. It puts too much pressure on the discs. And so I want to keep that curve, not too much, not too little. And so that's where chiropractors and massage therapists work together in tandem, is to bring health to that, keep the curve balanced, keep the curve in its natural state where it should be, and to bring it back to that point. So too much curve isn't good because you might have bone on bone and some other downsides, as well as too little curve, which causes too much wear and tear on the structure itself. A lot of folks give chiropractors a bad time for just like, well, all they do is just crunch my back, crunch, crunch, crunch. And again, I said before is that lack of movement is death. And chiropractors are dealing with spines that are not moving well enough, and there's a fixation, there's this lack of movement. You're likely to have more issues build up in there. And so they're just crunching down the back is better than none. Some are very specific in how they work, but in general, movement is good. And same is true with massage. If we just use an elbow up the spine, up the erector spinae, it's very, very, very beneficial. And just by taking 5 or 6 passes in your normal, massage that you're doing, just by 5 or 6 passes on a spine that's tight, the person's just stressed out, is going to help those multiple muscles in that group to start to let go. Most importantly, what often gets ignored, though, is the little muscles in the ditch, the lamina groove. And by working inside that ditch with the finger reinforced and digging and opening those muscles up, those control the angles of the vertebra, and those are not to be neglected. So make sure that as you do your work, dig in the groove, get those little guys to start moving better and to give them the help that they need. But just your finger in there, small movements as you work on those makes a big difference. Archimedes said, if I had a long enough lever and a strong enough fulcrum, I could move the world. We say lever because it sounds cool, an old saying. The idea is that a lever and a fulcrum is what allows you to lift something really, really heavy. And so if your car gets a flat tire and you pull to the side of the road and you open up the trunk and someone forgot to put the jack back, go find yourself a stop sign, work its way out of the ground. Don't tell the police I said this. And then roll a boulder up next to your car, and then put that 4x4 piece of wood or metal under your car, come back, and then press down. So this is the lever, and the rock is the fulcrum. The closer that rock to the car, the more power you have. The farther back that rock is, the more it becomes a ramp and really becomes not helpful at all. So it's like a teeter-totter. You put that fulcrum right in the middle, those equal strength. So if I want to lift up 100 pounds on this side, I have to give 100 pounds of force on this side with a center fulcrum, right? So if I want to have more strength, as I push that closer to the car, now 100 pounds gives me 200 pounds of strength. I push it even closer, now it gives me 500 pounds of strength. So as long as that fulcrum is strong enough, and so is the lever, I can lift pretty much anything. So Archimedes was basically saying I could move the world if I had a long enough lever and a strong enough fulcrum. Why am I talking about this? Well, your body has this thing called a sacrum, and all this power and all this stress comes right to that point. Before I got into massage therapy, I got out of college, I got my degree in business and marketing from Western. I moved forward and I achieved all my career goals really quick out of school. I had really dumb career goals, but I achieved them really quickly. I wanted to make more money than my dad. I wanted to have a home in Bellevue. I wanted to own, and I wanted to have a certain European luxury car. And I thought, well, that was stupid. I got all my goals really quick, and now what? So, but before I left that job that gave me those things, my goals, it was a commercial steel building company that built these warehouses for Costco and Boeing and Camera Truck and these big steel. Well, those steel frames that they used to support that roof have these bends in them, right, at the corners, and all that stress comes down. If you can imagine Boeing having an aircraft hangar 300 feet wide with no poles holding the roof up. And then we get a 3-foot snow, some crazy snow in the Northwest. Now it starts to rain because it warms up as it does here. And now we've got all this weight on the roof. All that weight, hundreds of pounds per square foot in some parts of the country, starts to push down on the roof. Well, where does that stress go? Well, it pushes out at the corners. And that's called a moment reaction. So when you're working on the body, all that stress of the body really comes down to the sacrum. And our posture makes a difference too. If I have a wide stance, I put some more pressure on my sacrum if I pull my feet together. What's also important to realize is that injury that takes place in a car accident, a lot of injury takes place in the SI joint, and those ligaments get overstressed, and that can be helped out by a number of ways. Everything from cross-fiber friction to prolotherapy. Proliferative injections can draw that back in and tighten it up, but essentially that's a very, very important part of your mechanics of your body. What that means to you is some of you are taught in school a technique for releasing the psoas where you put your hands into the psoas and you have the person lift their leg off the table. I don't care if it's lifted up a little bit or a lot, but let me explain some dynamics of force to you. If I have a 100-pound ball of concrete and I sit it on top of a stick and I hold that pole vertically, it takes a couple of pounds of strength to hold it in place. If I start to tilt that pole away from me, every time I hold it out a little bit farther, that gets heavier and heavier and heavier, and pretty soon I can't hold it in place at all. It's just too much for me. And so you have to realize that the dynamic of that weight is important. So the head, for example, let's just say my head for mathematical easiness here is 10 pounds. And if my head is perfectly postured on my neck and I'm looking like this, I've got 10 pounds of stress on my neck. As soon as I go 1 inch anterior movement, 1 inch anterior, it adds 10 pounds to that. Now I've got 20 pounds of stress on my neck. If I go 2 inches, now it's 30 pounds of stress. Every inch anterior, and pretty soon it just magnifies. So you have to realize that as we work on the body, the posture is important just to help keep the client better, but so is how you work on them on the table. And so when you're doing that kind of work and the person has a destabilized back, it's in an acute situation, low back pain, they crawled into your office practically, do not put pressure on that and have them lift their leg off the table. Once they're in the subacute phase and they're doing great, and you stabilize things and they're getting better, awesome. Use all those techniques that you learn, but make sure you get them stabilized first before you start doing things that can possibly put moment reaction stress on the sacrum and really exacerbate their injury and hit the ligaments and make them just get worse and worse. You want to help them get better and better instead. So the technique we're going to show in this in the class this morning is the psoas release technique. Now, people say, what's the iliopsoas? It's like, well, yeah, those two muscles together candy cane and spin and connect to your lesser trochanter, but we're just releasing psoas. There's very few people that I would ever work on that can actually get to the iliacus and not cause damage to the tissues just getting to it. So if I can release the psoas, oftentimes the iliacus instantly lets go at the same time. It just releases. So if you're super, super, thin, you've got stretchy skin, you've got, extra weight, and just, sure, I can get to it. Most of us real people, we can't get there. I've got a few friends who are, rolfers and Zen therapists that love to have that done. I'm not looking at anybody in particular, but as you dig into that, you can release it, but I prefer to let the psoas go first and let the rest of it cascade and settle down. So once they're out of the acute phase, you can do all the different work you want. You can cross fiber friction and trigger point and pin stretch and stretching work, and that's awesome. When they're walking in your door and they can't even walk, they're just walking over, bent over, they're in the acute phase, just get them out of pain. Has anybody been on their back for a week and couldn't move? You've had that kind of pain? It's scary. For those of you who have not had that, imagine when you had the flu, the worst ever you've ever had. And you're laying there in your bed, you're thinking, what does it feel like to feel normal again? You forgot what that feels like. It's the same with the back. It's actually kind of scary. You think, I might never walk again. You can't imagine. If it's just going out of your bed to go to the bathroom, it's exquisite, sharp shooting pains. It's scary. And so I want to get my client to a place where they can see the change. There's a psychological change in the brain when they go, there's hope. And literally, this is the fastest technique that I do that has almost instantaneous response. It's very, very quick. In a matter of moments, you work on them for just a few minutes, and they get off the pain, and you've dropped their pain by 50, 60, 90, 100%. They're like, oh my gosh. And this is a really fast technique, which brings up the philosophy of filling the hour. When you work for an employer that says, okay, you need to work on every client for 50 minutes, I have a really difficult time with that ethically. It's great for money, great for income, not good for the client. They may only need to have a 10-minute technique done to them, right? And the prescription says, treat for low back, and I treat them for the first 5 minutes. It's getting better, getting great. They're out of pain. Now they're getting worse and worse and worse and worse. And I leave them lay there on the table until they're out of pain. That's not good. You want to get your clients out of pain and get them off the table and get them moving. Don't make them lay there. Movement is life. Lack of movement is death. Get the pain gone. Get them moving. Don't have them go out dancing. Now, the first thing they want to do is go out dancing and doing all the yard work they hadn't gotten done, right? No, not too much of anything. So don't overtreat this. Get them done. Get them out and move them out the door. I often tell people, how long is it going to take? I'll say, I don't know. Maybe 15, 20 minutes. My fee is this, to get your back to feel better. Not based on time. Now, insurance companies, they're time-based. So if your doctor wants you to fill that space up, you're going to have to figure out what else to do and do this last. It's the last thing you do before you get them off the table. A couple other things to be aware of with this is that, I mentioned the 17-year-old, she tried everything else. This spasm of the psoas can kick into gear and fight against the low back muscles, and it can go on for decades. I've had people say, you get in a car wreck before? Well, yeah, it's like 15 years ago. You ever have this treated? No. But once you release it, boom, a huge change. So it's very fast. But it's something you can do pretty much anywhere. I was at a men's conference years ago with my dad. He invited me to come along for a weekend, and we're sitting there drinking coffee, and I don't know why men think that we are what we do. What do you do for a living, man? You know, so we're drinking coffee, and it gets around, and the guy goes, I'm a cop, and I'm a truck driver, and it gets to me, I'm a massage therapist, and I'll go, oh. I bet I fix backs and cause a lot of pain. You know, oh, really? I got back pain. You drive a truck, right? So I just laid the guy on the ground, did the technique for 3 minutes. That's all it was. And he gets up and goes, oh, my God, how'd you do that? Next guy, I got back pain. I ended up working on all these men, one after the other, and they said, you got a card? No. Oops. Now I teach classes on carry your cards. But the point is, it's really, really fast. I've done it in people's homes, at parties. I've done it, you know, I was in Rome at my bed and breakfast I was staying at here this last year, and the lady's back was killing her. Actually, first the husband was talking about carpal tunnel, and they fixed it really quick. Or I shouldn't use the word fix. People get mad when I say that. But I alleviated her pain with my techniques. And she's, and she said, you know, and she didn't speak English, her husband did. So I released that, and he said, well, she has back pain. And so I took the couch cushions, laid them right there on the floor in the middle of the entryway, and she gets up, and her back pain was gone. Just a matter of minutes. Now, if I treated her for half an hour, it wouldn't have worked. You've got to do it really quick, get the release, and get them moving again. Don't leave them there for half an hour after you get it to release. You have to get the motion, get them moving. If they were on the table, they came in for something else, mentioned they had back pain, get this done, work on it, have them wrap themselves up in their sheet toga style, step off the table, and see what it feels like before you leave the room. I want to see them see that change. It's gargantuan. It's huge for them. And as they watch that, they go, oh, my gosh. And you want to be there for that moment. And then don't leave them there. So say, okay, you can go get dressed. I'll leave the room so you can get dressed now. But it's the last thing that you do. A couple other notes for you that are very, very important, and this is really important. If you work on them and you relieve the pain, and the relief lasts 2 or 3 days, all they need is you, just massage therapy. If you do this technique, you release it typically 1, maybe 2 more treatments, and they're typically out of pain unless they go back to the perpetuating factor that may have caused this to begin with. If you treat this and the pain's relieved in the last 2 or 3 hours, there's a chiropractic component to this. Something is fixated and the muscles are responding to protect, and the problem is coming from that fixation. So you release this muscle, have them see a chiropractor within a half an hour after you're done, relieve that, and typically let's go. You got to remember there's an ego issue when it comes to chiropractors and massage therapists. So you've got to be able to work with that. I had a situation that's pretty sad. Another 17-year-old girl, daughter of somebody I went to high school with, and she called up and she said, hey, can you work on my daughter? Her back's killing her. I said, sure. So she comes in. I did the technique. She gets up. Oh, yeah, pain's gone. Great. I said, listen, 2 hours or 2 or 3 days, right? And so I said, call me back if you have any problems. So about 2 hours later, she calls me up and she says, you know what? Yeah, the pain's starting to come back. I said, great. Go ahead and call your chiropractor. Set up an appointment. My schedule's flexible. I'll go ahead and come in after, whenever it works for you. I'll work on your daughter. We'll send her right over to the chiropractor and get treated, and she should be done. Well, she comes, calls me back about 20 minutes later, and she said, I'm caught in the middle. I don't know what to do. I said, what are you talking about? She goes, well, the chiropractor said that if you treat her first, she won't work on her. I said, this is not to be boastful. I said, does your chiropractor know who I am and what I do? She goes, yeah, she knows about your school. And I said, how long has your chiropractor treated your daughter for this condition? She said, 2 years. So I said, okay, there's a bit of a concern that your chiropractor might look bad if I can do 1 treatment and she does 1 treatment and your daughter's done, because that would mean all this time she's been taking your money. So I have somebody else I want you to see, and I sent her to my chiropractor buddy who taught for our school. So you need to be able to realize sometimes there's ego with this, and it's very embarrassing for a chiropractor who does not believe in massage therapy to work with you, because if you can expedite healing processes that they weren't able to. So there's no reason. There's reason for both of us. I believe fully in chiropractic, and I believe fully in massage, and they're both necessary. But you need to work together in tandem to get people better. One thing I want to say about this muscle, when you work on, people come in complaining of pain typically in the quadriceps lumborum, lower erector muscles in general. And they both are really usually having a problem. I don't just blame QL, but we just use QL as a way to say it. But the quadriceps lumborum typically is where the pain is at. Problem is typically that you have an overbearing psoas muscle. That said, if you look at the skeletal models of your skeletons and massage schools, these lower floating ribs have these really cool things called wires that hold up the floating ribs. Oddly enough, you guys weren't born with wires to hold up your floating ribs. So when you see your books and everything else, you see this huge space between the lowest floating rib and the iliac crest. In reality, people with low back pain, many of them, the QL muscle is pulling down so hard on the quadriceps or on the lowest floating rib, it's touching the iliac crest. And so when we find our landmarks, we find it and we go between the lowest floating rib and the iliac crest. And when I do this demonstration, every class I teach around the country, I always have people that have some serious problems with their low back, and then we go in to palpate, and sure enough, I say, okay, here's the float, they can see it, lowest rib, and here's the iliac crest, and I can barely get 2 fingers between. So when it's pulling down and just pulling really hard on that, we've got to be able to release it to get it to go back up. But so if they say, yeah, it kind of hurts to do this, I get a pokey sensation, that's because their floating rib is actually touching the iliac crest. It's a very, very powerful muscle. So be aware of that when you're working on people for this injury. I had a woman in Minnesota who volunteered to be the model on the table, and the whole class was quietly gasped because she weighed about 400 pounds. And they're thinking, okay, really? How are you going to get to this person's psoas? Well, first of all, when you have someone that's large and they lay on their back, most of the fat starts to go laterally, so it makes it easier to get to it. So their thickness still isn't that deep, and their spine, their back fat's there too, so their spine's in the middle. It's really not going that deep to get to it. But even if I can't touch it, when I use my elbow to go into the psoas, which sounds funny, but fingertips are more painful than an elbow. If we do this right, you go in, just the intent of going in there, the fascial connections as you go through that web of tissue, when you put pressure and they breathe deeply against that, and that pressure of the breathing causes the psoas to let go. So I may not even be on it, but all the interconnected tissues with that give me the benefit, and I still get the release. So regardless of size, you're able to do that. Let's talk about biceps tendonitis. You know, when someone tells you, you know, when I go to bed at night and I go to lay down, my shoulder just starts to throb. When they say that, that's the buzzwords for look for bicipital tendonitis. That's typically the easiest way to say, but you know what? If it doesn't hurt when you touch it, it probably isn't a problem. If it does hurt when you touch it, probably is a problem. So what we want to do is we want to isolate that, do cross-fiber friction, and release that with some ice. I do want to say that when you do this work, the tendon typically isn't the problem. It's the musculotendinous junction of the biceps tendon into the muscle belly itself. And typically, most injuries are in the short head in front, not the lateral head. And I'll show you this in a few moments, but realize that's where most of the problem is. The hardest part is actually isolating that, and we'll show you how to do that. The next piece I want to talk about is supraspinatus tendonitis. If you look at the actual graphic of the supraspinatus, it comes out just below the AC joint. So if I put the person's arm behind their back, or better yet, have them do it, because if they've had a dislocated shoulder or such, or have a weakness there, I don't want to dislocate it again. So they pull it behind their back, expose the tendon. We go and we locate that, do cross-fiber friction, grind it for about 30 seconds, really aggressively, and then ice it, and typically twice in a week, and the person's feeling much better. You know, years ago, I used to be had a massage office in a very affluent health club, and a lot of my clients would travel quite a bit. And this is, believe it or not, I've been a massage therapist longer than they had wheels on suitcases. I know, hard to imagine, isn't it? You guys are going, no way! So they didn't have wheels, so a lot of my clients were running through airports when they're late, and they're carrying this, and of course your supraspinatus is the first 10 to 15% of abduction away from the body, and so they're bouncing this, and they come home going, oh, my shoulders are killing me. Well, they gave themselves supraspinatus tendonitis. Well, now they've got wheels, and they're running like this, now they got bicipital tendonitis. So, you know, we'll show you the technique all at once. So I'm going to show you and demonstrate to you how do you isolate and locate that. When you want to isolate the short head of the bicipital tendon, so we have a long head on the side, and of course, if that hurts, then rub it too. But to isolate the short head, we're going to hook her armpit with our finger. Just hook it right here. Go lateral about an inch, and if you strum right across there, most people who are massage therapists have some discomfort when you go across that. Is that uncomfortable? A little bit? No? You want it to be? So if it has a problem, guess what? It's going to hurt. So if it doesn't hurt, then don't rub it. So you come across there, you hook it, come lateral, go cross fiber friction, and it's going to exquisitely hurt. So look at the clock, find a 30-second hand, and say, tell me when to start. And for 30 seconds, grind aggressively for 30 seconds. If you go really super aggressive, and you ice it down, typically twice in a week, and they're done. If I go gently and go, oh, is this better? You know, it might take a lot more treatments. I'd rather get them done quickly, get them over with, and get them moving and get that pain down. For supraspinatus tendonitis, we want to find that tendon by pulling the arm behind the back, have her hold it, and pull that and expose the tendon. So we'll find the bone, the most lateral point. You'll find bone, 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 bone. Keep going until you find that lip. And this is going to be different on every person you work on. That's why you want to practice this. But you find that lip, and you're going to go anterior along that ridge until you find a little tendon that pops up and down. When you strum across that, it really does hurt. And if they have an issue with that, you're on it. So you're going to grind it. The problem with how this is drawn in books and shown is that it's often drawn much more broad, when in reality it's like a pencil. It's a very thin tendon vertically on most people because as it's got a problem and an issue, it's tight, it draws itself tighter and more thin. So be aware of that, come across the top. And again, if it hurts, rub it. If it doesn't, that's not the problem, right? So go across, follow that ridge. As you go across the bone, follow the ridge forward a little bit, and you'll find a vertical tendon. Again, cross fiber friction, really aggressively, 30 seconds, followed by an ice cube with paper towel. Make sure you're wiping it as you go, and you'll see this on the DVD, but it allows the water to keep from running down the arm. Cross fiber friction and ice until it stays cold and you're done. Thanks. This next section, this discussion is really short. It's a seated massage routine. You know, a lot of times I can do better work on the neck, for example, in a seated position on a stool than I can on the massage table where I'm lifting the head up and that kind of a thing. And so I'm going to show you some techniques in a seated position. You can do this in any chair. You can actually do it with clothes on except for the very last piece, which is the knuckles down the back, which I don't want to have knuckles on clothing. But in general, the rest of it can be done seated, and you can actually get range of motion work in a seated position better. So when your clients, they come in, if they know you're going to do this, perhaps you can have them bring some bicycle shorts and a tube top or something like that, some kind of a exposed top or some kind of a bikini top that works for them. You can have exposed shoulders and do this on the stool. Trying to drape with that, they still can do that too. They can wrap a sheet around themselves or hold it to their chest and do this work fairly simply. So it's an extra piece of material, and I wanted to cover to give you some options that you can do versus just table work. On pectoralis minor, rhomboid balancing, it's not rocket science, but I do want to make sure you understand that when someone has an impingement, a tightness in pectoralis minor, and impinges that nerve, it can mimic carpal tunnel. And so I've actually, doctors themselves admit in medical journals that they are wrong 50% of the time in tests to isolate thoracic outlet syndrome. 50% of the time they're wrong. And if medical doctors are wrong, how much better are we? Right? Well, I don't like to do tests. If it hurts, rub it. So when it comes to carpal tunnel work, and it comes to issues of thoracic outlet, you know what? It takes 5 minutes to work on both. Work them both. Don't guess and miss one. Just do them both. So if I have issues with that, I work on all the thoracic outlet. I test it by touching it. That's my test. Push, push, push. Work the areas. Work the carpal tunnel. And when you release both of those, you're shooting fish in a rain barrel versus going, right? So you just don't guess. Just do them both, and you're likely to have that covered. Another couple issues to be aware of that with is that when you've got a spasm in the rhomboid, that fights back against a tight pectoralis minor, that trigger point in the rhomboid feels like you're having a heart attack. Matter of fact, in the book we used to say false heart attack, but my lawyer said, dude, really? He didn't say dude, he's old, but he said if you put the false heart attack in there and someone is having a heart attack and you say, oh no, I'm sure it's a rhomboid trigger point, not a good idea. He said, so don't put that in there. But the point is that trigger point in the rhomboid, when that thing fires, it's hard to get a deep breath. It shoots through the chest like you're having a heart attack. And I was at a buddy of mine's office once a number of years ago, and I oh man, I had a heart attack, I think. He goes, what? And I go, it's this pain shooting through my chest. And he walks up and pokes me in the rhomboid. I go, ow! He goes, you know this stuff. You teach it. I go, yeah, but it's me. We get dumb real quick when it's ourselves, right? So be aware that trigger point can really make it difficult to breathe. Get in there. What I use for myself, massage therapists, we never get the number of massages we need, but the Body Back Buddy, it sounds a little sissy to me, so I call it the Klingon tool of death. But you can buy these things. They hook around the back and just work your own trigger points. So really get into those guys and break those up. When it comes to stretching with this, though, I can do all the great work I want on pectoralis minor. I can stretch it and work it. But in truth, unless the client takes the time daily, takes the time to really work on that stretch, it's not going to get well. So we want to deal with that by having the client do a self-stretch. Now, I used to show it in the doorway. They stand in the doorway, heels equal, side to side, catch the door frame, lean forward, and pull their shoulders back. The problem with that is if they have any kind of shoulder issue going on simultaneously, we're going to exacerbate the shoulder issue to fix something else. So instead, and plus they look kind of dumb at work when they're doing that. They feel self-conscious. So what I want you to do is take your fingers. I want you to put your fingertips into alignment. And if you, as a therapist, have long nails, snap them off right now. For some reason in Florida, they've all got long nails. But so I want you to go ahead and I want you to palpate your pec minor. Okay? So come in here. The pec minor goes from the coracoid process of the scapula down the rib cage. And we're going to go ahead and we're going to take our fingers. right? And we're going to isolate that. Now, don't push on it yet. Pull your shoulder forward. Put pressure on that muscle belly. Go down towards this elbow. So we're going to go down, hold it, and then pull your shoulder back. That's what I want to hear. So we're going to go ahead and do a pull that back. Your client needs to do that 3 times a day for 30 seconds each. Okay? So it's really important. So as long as they're doing that, it's going to stretch it out. A lot of clients that deal with bronchitis and asthma and those kinds of things, you know, they start to get, the intercostal muscles start to get shorter and shorter and shorter. As a matter of fact, just as Americans, I don't care what ethnicity you are in your background, heritage-wise, when you deal with intercostals, most Americans have very little space between our ribs. So, you know, you look at people in foreign countries who eat well, eat vegetables and rice and healthy foods, typically have a larger space between their costal bones. Whereas Americans, when you talk about our chemicals in our food and other things, we start to have these intrinsic muscles start to really tighten up. And if you put fingers between your ribs, you might find your ribs are one on top of the other, actually touching each other. And so if they are, if your rib cage is drawn up, it's not as effective in bringing oxygen into your body as it should be. And you're wondering, why am I dealing with intercostals when it comes to injury? Well, if I can increase your oxygen intake by 25%, I'm also decreasing your spasm levels at the same time. And if I can systemically drop your spasm levels, I'm dropping your pain in general and helping that treatment process along. So I want to show you a few techniques. We're going to put some pressure on the chest itself and put pressure and resist against that where the breathing has to fight against it. You know, this is one of the principles is, have you ever gone running and you got a stitch in your side, that cramp hurts like crazy? Well, I'm going to look foolish doing this, but I don't care. So what I want to do is I'll take a nice deep breath, arch my back backwards, take a nice deep breath, lock it, and then drop myself forward into a crunched position. And it's going to force and force and force and force pressure outward, breaking that spasm on the intercostals and the diaphragm. So I get a nice deep breath, go. And as they come down, it pops it out and stops that stitch almost immediately. So you can have your clients do that if they're runners and that kind of a thing, but also that principle is what we're going to use when it comes to increasing your breathing. Makes a big difference. The one technique on the actual intercostal work, it's really painful. We're just doing one set of ribs for today. You'll be going between the bones and crowbarring apart these ribs. It doesn't feel good. If you do it to a client their first time in, they will never come back. So they need to be asking you to have this done. You know, most people, my voice right now is unamplified. I'm up an octave versus my normal voice. My voice is actually lower than this. But if I talk down there, you actually are like, what? So my voice has to be higher to be heard. As we get older as men, our voices get higher anyway. Hey, Sonny, how are you? Right? And women, as they get older, their voices drop down. So it's kind of funny to me. But anyway, I had a gentleman come in from the Seattle Opera, and his voice was getting, so he couldn't quite get the low notes as well as he used to. So he thought, I know, I'll start smoking. So he got a raspier voice, and now he's got spasm, especially intrinsic muscles. The intercostals and things are much more likely to spasm. And then he's like, great, now I got a raspy voice. I still can't hit my notes, and I feel like crap. I said, well, get off the cigarettes. We did this technique to him, and immediately it dropped down. After a massage, my voice even drops another octave lower. As I relax, you just get that nice relaxation thing. So this is really helpful stuff. We are going to do some diaphragm release as well in this. And then the upper fibers of rectus abdominis will be reached at the same time today. So we hit the lower fibers with the technique on releasing the lower abdominals earlier. Now we're going to be hitting the upper fibers as well as the diaphragm and trying to break that up. So make sure this technique, we're going to have the person move down a bit. We'll be getting on top of the table. If your table is not designed for that extra weight of you being on top of it, some of the tables, I don't want to pick on Costco, but their older tables were not designed for that kind of weight. There's a difference between the specifications of a table of static weight versus dynamic weight. We're getting back into engineering. There's an old golden ratio advertisement they used to put in the EMT journal of an old antique truck sitting on top of their table. So if I lowered that table, the truck on top of the table and backed away really carefully, that's static weight. If I just pushed in that truck with my finger, that table would collapse. That's dynamic weight. So when I have two people working on top of a table, we're working, that weight is different. And a long time ago, we had a problem with the table company, and their tables failed because they had a component problem. They were embarrassed. They wanted to prove the tables were cool and better than anybody else's. And they brought me in. They flew me into their state, which I'll say, leave nameless. And I flew into they opened up 10 boxes of 10 different brands of tables. They bought their competitors' tables because our school was buying a lot of tables at the time and they wanted to keep my business. And they dropped steel plates, 450 pounds on each individual table and crushed them all, except for theirs. So you want to make sure that the table's designed for dynamic weight because you're going to be on top of this kind of thing. If not, take the legs off the table, stand next to it, and do the work right next to that table. The last four muscles that we're going to work on in this section, the first one of those is the teres minor. It's one of the four muscles that holds the shoulder and the girdle. You'd think it'd be teres major, but no, it's teres minor. And that muscle typically isn't really an injury problem muscle, but it is a trigger point problem muscle. And when that muscle gets a trigger point, it's really confusing because it'll cause a trigger point to hover over the deltoid tuberosity. And so when someone says, it kind of hurts here, think about the trigger point that's going on back in the teres minor. So they paint it on. They point at it, it's probably bursitis. Again, I would never say that, but right? They paint it like this, it's probably going on, it's a trigger point referral. So I'm going to show you a technique, and that muscle is designed to actually assist the latissimus dorsi, but I want to just be aware of that referred pain pattern. I'll show you a nice little technique, we're going to glide through it and work on the trigger points. The next is infraspinatus. And the infraspinatus muscle, if you look on the screen, if we outline the infraspinatus, the lower inferior borders, and the spine of the scapula, 1 inch in from all of those borders, you have an imaginary triangle. Every single place you push in there is a trigger point. You can't miss. And the nice thing about this, it's great for teaching students trigger point referral patterns because everywhere you push, that pain shoots up over the top of the shoulder, down the back of the arm, down the back of the hand, into the fingers. And you put the pressure back off, it comes right back up like a thermometer, push harder, goes right back down again. And so it's like a thermometer in that referred pain pattern. But all we're going to do on that one is pretty much squish it. Nice technique for that. So the infraspinatus, we're doing trigger point release on that. We're putting compression on those. I do want to discuss really quick about the theory of trigger point release. And there's different philosophies on this. And some people think you should put pressure on there as hard as you can for like a minute, and eventually it does dissolve. That's true, it will, but the client typically won't come back. You don't have to be mean. So Bonnie Pruden feels 4 to 7 seconds. I'm kind of in that same vicinity. I think you should push about 4 seconds or so, release and come back in. And the reason is that it causes ischemic pressure. Janet Travell, and this sounds like heresy, but Janet Travell was wrong as to why trigger point pressure worked. And they asked her, they said, why does it work when you press on a trigger point? She says it deprives it of oxygen. The problem is in scientific studies since her death, we've found that actually trigger points are already oxygen deprived. And so when we're putting pressure on those trigger points and releasing and coming back in again, it's ischemic pressure. We're bringing fresh blood to the area. And that releases not just the trigger point, but the other muscles associated and supporting, and that lets the muscle let go, lets the trigger points let go, from my perspective. So I prefer multiple compressions versus one long compression from the standpoint of extra oxygen. The last muscle, you may have noticed throughout the weekend, we didn't use any lubricants at all. I pretty much work on people with very little lubricant at all, unless I'm like chirping across their skin because there's no lubrication. If you cause enough pain, of course, they sweat, and that's free lubrication. But as we work on them, I use very little because I get free fascial work out of the deal at the same time. So by having that, if I just have oil, I'm slipping and sliding. I'm not doing as much myofascial work as I could be. But as I work on people in subscapularis work, we're going to use a lot of oil today, and I'll explain why in a minute. Years ago, I had a woman who worked at the hospital where I had my school, and she called me up in tears. And she was just said, Bob, I'm in massive pain. And she was just sobbing on the phone. She said, can you please help me? My shoulder won't move. I said, come on up. So she came up to the student clinic, and I saw her, and I said, well, what happened? She said, well, I was working in the garden. I worked all day and work. And that night, my husband told me I should put some ice on it because it was hurting. And then the next night, he owned a sporting goods store, the kind that sold rackets and weights and those kinds of things. So we heard a lot of hearsay hydrotherapy advice. And so she said, well, the next day, he said, well, spend 24 hours, put some ice on it. And after 72 hours, it was still hurting. He said, well, spend 72 hours, put some heat on it. So she put a hot pack on her shoulder and went to bed, igniting the inflammation process, waking up next morning with frozen shoulder. And so when she came in, I used a technique of trigger point release that is very, very effective. But it didn't work for her, which ticked me off. My techniques worked. And so that day I added a PNF piece where we're able to do push, push, pull, pull, push, push, pull, pull. And within 10 minutes, we had her to full 90 degrees. If you get to the 90 degrees in 10 minutes, you've succeeded. And so the nice thing about doing PNF style work is it resets the brain. It allows it to go where it couldn't have gone before. If you trick it, that's not a good way. So they've tried where they've, I don't want to be gross, but when you're under general anesthesia, everything relaxes, right? Even your anus totally relaxes. So they do surgeries for hemorrhoids and such. They put you under, totally opens up. They can do the surgery, right as a duck's butt, and off you go, right? So with general anesthesia, when it comes to the shoulder, it totally lets go. And they can chain your arm to the gurney, and you wake up and go, oh, cool, look at that, right? Problem is, within 2 weeks, pulls right back to where it was. So it doesn't work. It doesn't work the right mechanism, but PNF does. Now, one of the frustrations for me as a massage therapist is I was taught a way, it was okay, but it wasn't the greatest of ways. And so if you're working on a patient when they're face up, supine, typically they want to help you. And so they're engaging muscles that should be flaccid and relaxed, but they're engaging and helping you. So I don't like to work with the patient for subscap face up. When they're face down into a prone position, the technique is you come up over the shoulder and you go up right into the scapula. You hit this web of tissue, and it really hurts to get where you need to go. And my first couple of years as a therapist, I was thinking, there's got to be a better way. And I was working on a woman, and she was laying there, and she was a friend of mine. So I had a number of clients that I worked on. The agreement was that I'd work on them for free, and I got to do whatever I wanted and experiment on them. And so it was win-lose, but I'm just kidding. So I was able to really be aggressive and do things. But she was laying there. She's a friend, and I said, her breasts were poking out the side, and she lay there, and I thought, man, it's just nerve-wracking going near the breast because I don't want to get in trouble doing something inappropriate. And she was laying there, and I put my hand on the side, and I said, does this feel like it's your breast tissue? And she said, no, huh? I went, huh. Next client that came as a friend of mine I was working on, I said, she was laying there, her breasts were bulging out to the side a bit, and I touched the side, I said, does this feel like it's your breast tissue? And she said, no. I thought, that's really weird. So I asked about 4 of these people in a row over a period of a week, and they all said, no, it doesn't feel like it's my breast tissue. And I thought, huh. Well, if that's the case, if I'm able to work in that area and not freak them out because I'm touching their breast, I have a lot more latitude. So I started putting lubrication. I put a lot of oil in the armpit, and I kept swooping my hands and swooping until the whole thing was smooth. And I cupped it right up under to the axilla. I came right up inside, and I was a 1/4 of an inch from the trigger points, and they feel no discomfort. And you just go push them together, and then it hurts. But until that moment, if you scoop it through and you come up on the inside, there's zero discomfort. And so that's what we're going to show it to you different in this class, is that if you're able to get past the mental block of I'm touching breast tissue, check it and try it, you'll see that you're really not. It's touching the sides, and they don't perceive that as breast tissue. Of course, you've got the fat squishing out from the side. That's normal. As you come up inside, you're able to get just below the trigger point, press it, and then it hurts, like it would normally. But you're not causing damage to the tissues just to get to it. The trigger point piece, adding on top of that, we're able to really get the range of motion. And of course, trigger point work is good, but the PNF piece, when we start doing PNF work, it really does reset the brain and allows it to let go in ways it hadn't before. So we'll show you that technique as well.